Hi, good evening, everyone. Welcome to our webinar, Joe. And this is the first time Joe is giving us a webinar. And it's been a long time since we had a webinar on psychiatry. I do not know why, because it is something that is so important, especially in the era of COVID. And now with a lot of kids having mental health issues. I know we are opening up, but this COVID induced mental health doesn't seem to go away in many people. So without further ado, we invite Joe to give us a talk on this topic. Just to say that I can't share the link in Beating Hearts. So watch it on, anyone can watch it on my page. Never mind, we go ahead. First, let me settle this.
Thanks, Betty. Let me try to share. Sorry, just give me 1 second. Let me try to share. Yeah, okay.
Okay.
Okay, Betty, can you just check for me? Is the screen?
Yeah, it's fine.
Okay,
it's
fine.
all
right.
good. Yeah.
Okay, thanks for the invitation. So let me just go through briefly. The title is Depression in the Era of COVID. But then I'll just be speaking a little bit about a mixture of like depression and anxiety, because anxiety is always comorbid. So it'll be a mix of depression plus anxiety a little bit, and what has happened to mental health statistics during the COVID era. So just a flashback. So when I was preparing the slides for this talk, I happened to come across this particular slide of mine. And I think I gave this talk in June 2020, right? It was on the 3rd of June. And at that time, number of infected was 6 million, number of deaths was 300 plus thousand. This worldwide, recovered was 3 million plus. So trying to show people that even though it's spreading very quickly, but a lot of people are recovering as well. And no end in sight. I actually stated that this was in June 2020, no end in sight. Economic toll, worst economic recession since World War II, etc., personal cost. So looking back at this right now, I'm so glad we are where we are right now, because back in the day, we really didn't know what was going on, MCO after MCO and stuff like that. So during that time, so when I was preparing talks, so during the MCO time, we did a lot of webinars because we knew that mental health became an echo pandemic, whereby COVID-19 became a pandemic, but then we were expecting mental health issues to become very, very drastic and prevalent as well. So we look at a few things now. So earlier on, these were all in the early 2020s, mid-2020 results. Loneliness became an issue. So in the US, they did a study. So there were 93% of them were in shelter in place. We call it MCO in Malaysia. In the US, they call it shelter in place. So most of them were in shelter. And then for those who were in shelter, 61% of them felt socially isolated. I think we all felt that way during that time. Then subsequently, 43% of them actually felt a high level of loneliness. Yeah, so it became quite a drastic issue. And then factors associated with mental health outcomes among healthcare workers exposed to COVID. So depression became very prevalent. This earlier on, we couldn't get statistics about the general population, simply because MCO was in place worldwide. Everybody was isolated at home. So they did studies among the healthcare workers. 50% of them experienced depressive symptoms. Anxiety was 44.6%. Insomnia was 34%. 2/3 of the healthcare workers were experiencing distress at that point in time. So this was done in 2020. So you can see that the depression was very prevalent, anxiety was very prevalent. And then they did 13 studies, out of which 12 studies were done in China, 1 study was done in Singapore. Out of 33,000 healthcare workers, so they did various types of scales. They found that 23% of the healthcare workers at that point in time were experiencing a lot of anxiety symptoms. These are anxiety disorders, right? These are not just anxiety symptoms. and they were experiencing major depressive disorder, and insomnia was very, very prevalent, as I am sure most of us had some level of sleep issues during that time as well. Then with the kind permission of Sylvia, they will allow me to use this slide. So we talk about prevalence of anxiety in major depressive disorder. So major depressive disorder on its own is already quite devastating, but frequently it's very comorbid with anxiety disorders. So 37% of patients with MDD will suffer from an anxiety disorder during their lifetime, right? And most of it, out of which is generalized anxiety disorder. Some of them have social phobia, which is the inability to go out to the public places or crowded places and all. During the MCO, then we found that a lot of people develop social anxiety disorder. So patients with MDD are 4 times more likely to experience anxiety disorders compared to individuals without major depressive disorder. So anyone with major depressive disorder, with depression or any psychiatric diagnosis, they tend to develop more comorbidities, meaning that coexisting illnesses. And then in patients with major depressive disorder, right? So a lot of them, we now have a sub-specifier, we call them anxious distress. A lot of the patients with major depressive disorder, they experience a lot of like anxiety symptoms as well, feeling keyed up, being unusually restless, having trouble concentrating due to worry, feeling like something awful would happen, thinking one might lose control, etc., etc. So in patients presenting with first episode of depression, the prevalence of anxiety symptoms may be as high as 80%, right? out of which most of them are mild to moderate, and some of them are moderate to severe. So major depressive disorder, like how do you, I mean, like for psychiatrists, how do we diagnose you as major depressive disorder? So you have to have 5 symptoms out of the nine symptoms. The 2 symptoms shown here in this little box. The first symptom is depressed mood and or anhedonia. Anhedonia is just the lack of joy, the inability to experience joy or pleasure. So the patient has to have one of these symptoms, right? So some of them do not present with a very clear-cut depressed mood. They just present that I don't feel like there's a purpose in anything. I don't feel like life is worth. I mean, like there's no joy, there's no pleasure. So you have to have one of these core symptoms plus another 4 of these other symptoms, accompanied by either thoughts of death, energy level, which is usually very, very low, focus and concentration is usually affected, and they feel excessive feelings of guilt and worthlessness. Appetite and weight, they can either increase appetite or lose appetite, but most of the time they lose appetite, they start to lose weight. 5 to 10 kilos within 3 to 6 months is very, very common. Partly there's no pleasure in food anymore, partly it's like they do not have appetite to eat at all. I will explain why later on. Then psychomotor changes, I mean the psychological and even the physical or motor symptoms, everything is all very slow. So they walk more slowly, they do things more slowly, simply because focus concentration is not there, energy level is not there, so they are unable to do things quickly. And sleep disturbance, you can have either insomnia or hypersomnia, right? So psychiatry as it is always sometimes quite confusing, and this kind of presentations or symptoms do not help matters. So, okay, so if you have all these symptoms, maybe 5 out of the 9 or maybe all 9 symptoms, so what, right? So when do we diagnose it to be a disorder? So whenever psychiatrists say that you have a disorder, regardless whether it's an anxiety disorder or major depressive disorder, you have to have a level of functional impairment. So the duration is more than 2 weeks, depending on the severity, but usually it has to be more than 2 weeks. If it's just 3-4 days, then we do not count it as major depressive disorder. But if your functioning is affected in any way, right, in terms of work, in terms of ability to socialize or to mingle or to do anything, right? So if that is the case, then we will classify as a disorder. So whenever we say a disorder, it means that you are unable to function. And I'll go into the functioning from all aspects of our lives later. So briefly, let me just touch on generalized anxiety disorder. So generalized anxiety disorder is just basically excessive worry and anxiety for more than 6 months, difficult to control the worry, they are restless, they're easily fatigued, difficulty in concentrating and mind going blank, irritability, muscle tension, and sleep disturbance. And this caused a significant distress. So psychiatrists always talk about significant distress or impairment in social, occupational, or other important areas of functioning. That's when we classify as a disorder. So sometimes when we are just a bit anxious or we're just a bit depressed, it does not qualify for a disorder. And generalized anxiety is it's a tendency for a patient to worry about everything and also worry about nothing, right? So that's why we call it generalized. So they tend to worry about a lot of things. And it's excessive and you cannot control it. So many shades of depression in the sense, I wanted to write 50 shades, but then, okay, this is, I think, umum type of like webinar. We have a lot of names, so that's very confusing, right? So the actual term is major depressive disorder, MDD. Sometimes we used to call it major, sometimes people use major depression loosely. A lot of people want to classify it from the normal depressed mood after breaking up with the boyfriend or the girlfriend, or we call it clinical depression or unipolar depression or depression on its own. Melancholic depression is an older term, or we use it to classify certain more physical symptoms like low energy, inability to focus, concentrate, sleep disturbance, etc. And I think for the lay people, sometimes they call it walking or smiling depression, because on the surface, on the exterior, you appear very, very normal. Then when you go back home, you start crying, you start breaking down, you start going through like severely depressed mode, negative thoughts, suicidal thoughts. But when you are with people, then you appear to be fine, right? So that's...
Is that a disorder? Is that
it's just a term, yeah, it's just a term that some people use, but basically it is a major depressive disorder. So it's just that on the surface.
It's not a major depressive disorder.
Yes, so they are actually depressed, but it's just that, like they are not so depressed yet, whereby they can still mask their symptoms and they can just appear to be normal, like you and me. And then when we're on our own, then it's like completely different.
I had this when I was going through my divorce.
Oh, okay.
Depression. Right. I could work. Everybody look at me as if it's normal. But the moment I go into the car, then I go depressed.
Right. But then that may not have been, that may not have necessarily been major depressive disorder, because let's say we go through a major life event like divorce or anything else, right? You actually have an adjustment disorder as well, right? So that one will not be classified under major depressive disorder.
But I do have like the crying episode. I was I also had suicidal thoughts. I couldn't function out of the hospital or the moment I go into my car after work, I get depression. Yeah. Okay,
but you could still hold it together that when you're working, then you're still, like
but I was right outside work.
Right.
Yeah. Right. What was like my salvation, basically.
Right.
Yeah.
So it was still manageable in the sense that you could still, distract yourself by focusing on work and all. So yeah, so this is, this is very common, right? So this is why it's scary sometimes that, like on the surface, you still look okay. Everybody still looks okay. So then coming to the question, psychiatrists always say this because most people think that, okay, if you have depression, then you can snap out of depression. Can you snap out of depression? So depression, is it will, mind over matter, willpower, etc., etc., etc. So this is where psychiatrists will get very frustrated, but at the same time, we have to show exterior of Zen to tell people that, look, you cannot snap out of depression, just like you can't snap out of diabetes, right? So this is the what people describe having depression is like. It's like running underwater. This is where the psychomotor retardation is very, very significant. They feel like they're slowed down when they walk, when they run, when they do something. It's like running underwater. They're encased in an electric force field, meaning that they're unable to feel. They're blunted. They are emotionally suppressed, and they are very slowed down in a lot of things. Yeah. So this is just a description by a lot of people, like when they're going through that. I think for people who do not have depression, like Dr. Betty, since you mentioned that you've gone through that, so you know that when you're in that state of mind, it's very difficult to just get out of it. So advice from people like, I know that don't worry so much, I don't think so much, just go for a holiday or something like that. It will cheer you up, but it doesn't work that way.
Yes.
Yeah. So then if we talk about, we talked about the symptoms. Then we want to know, like in medical line, we all want to know about the pathophysiology for those who are not doctors or in the healthcare, meaning that the biological basis, meaning that what causes depression, right? So is it willpower? Is it mind over matter? Is it lack of zenness or whatsoever? So we talk about the pathophysiology of depression and anxiety disorders, meaning that we look into the biological basis now. So I'll just share with you some of the things. So obviously there's a biological, genetics, and psychosocial factors. So we talk about epigenetics. Genetics, so there's a propensity to develop depression if, let's say, there's a strong family history of depression, right? But then we also look at the environment. So someone who has a tendency to develop depression, because genetically they're more inclined, there's a genetic loading, but they do not necessarily develop depression because maybe there's no major stresses in their life. So the second point is that in general, individuals with generalized anxiety disorder, they are in a more physiological dysregulated state, meaning that they have lower heart rate variability, so they tend to have high fluctuation, high heart rate, higher skin conductance levels, autonomic nervous system dysfunction. I'll describe the symptoms later on. And then the amygdala, one part of the brain, the almond-shaped part of the brain, small, tiny part of the brain, plays a crucial role in evaluating the emotional significance of stimuli. So the fight or flight response, right? So everything in that network goes haywire. So this is why a person with depression and anxiety respond in a very, very strong way. I'll describe the symptoms a little bit later. And then besides that, so I'm trying to emphasize a lot on the brain structural anomalies, the neurotransmitter deficiencies, so that we can understand that this is not something you can snap out of, right? This is something very biological. So we look at a few changes that we see in the brain. I mean, as imaging becomes more advanced, it becomes clearer to us to identify parts of the brain. So the prefrontal cortex, which is the front part of the brain, right? So they have the reduced prefrontal cortex glial cells. So glial cells is just like a filler cells in a way. They are important in regulating neurotransmitters, in regulating the myelin sheath of the nerves and all. So in depressed patients, it's always reduced density. And there's also decrease in gray matter volume. So the parts of the brain shrink a little bit, which is actually the volume gets restored upon treatment. Reductions in the rostro-orbitofrontal cortex thickness and neuronal cell body size. This one is just fancy words to impress the lay people, right? But basically it's just that there's just, what we are trying to point is that there's a reduction or decrease in the gray matter volume. And then the anterior cingulate cortex. So these are all the part of the limbic system which regulates emotions. So decrease in branch length and number of pyramidal neurons. So again, they are responsible for various parts of the emotions regulations. Hippocampus, which is important for focus memory, there are also reductions in total hippocampal volume. So basically, we are trying to say that, look, there are brain structural anomalies in a lot of patients with depression, and a lot of these structural anomalies actually gets restored upon treatment. And this is just another, yeah.
So you can actually see it on MRI?
Yeah, so they've done scans and everything, whereby and studies now, whereby depressed patients, as in this slide, whereby they find that the gray matter volume in certain parts of the brain, basically there is a reduction, and then especially the hippocampus part, and upon treatment, then it gets restored, right? Neurogenesis. So the patient becomes better, because another thing that actually, okay, I'll go into the neurotransmitters later on. And then more slides. These are the glial cells that I spoke about earlier. So on the right side is a patient with depression. On the left side is a person with a normal kind of like mood. So the glial cells, which is responsible for a lot of like functions and maintaining the homeostasis or the environment of the internal environment, is reduced in patients with depression. And then this is the scans, PET scans of a patient with depression. We talk about the dorsolateral, meaning that the front part of the brain, the upper part of the brain, side of the brain, the prefrontal cortex, and the dorsal anterior cingulate cortex. So these are the areas whereby it's part of the limbic system which regulates mood. Again, the blues and the red shows that the certain areas are supposed to be active, they become hypoactive, meaning that they are less active. And the certain parts of the brain that's supposed to regulate emotions, they become overactive in regulating. And the next slide will show that the B, the lower side, is supposed to be the normal. So the above one is the one that's like the previous slide. After treatment, it becomes the lower 3 sections of the brain, whereby it becomes more normalized. Yeah. So this is what we go through the slides with during the psychiatry training and to our psychiatry trainees in the college.
But what can trigger this change in size of the
So I guess,
gray matter?
yeah. So I guess there's always a genetic predisposition, right? So some of us, for example, if let's say my parents, father has depression, mother has depression, then the likelihood of me to develop depression is probably 20 to 30%, right? If only one parent has it, it's about 10+%. But twin studies show that 50%. So there's a genetic predisposition, and all you need is a perfect storm. It has to be the right trigger, and the trigger has to be something that affects me a lot. So, for example, if money is very important to me, and if let's say I go through some financial difficulties, and that would trigger me, right? If I go through relationship difficulties, that may not trigger me. If I go through work difficulties, it may not trigger me. But if money has always been an issue with me, and if I have the genetic predisposition, that means I'm genetically vulnerable to certain stresses, then it will actually trigger my depression. I guess, yeah,
Well,
like all other medical illnesses.
But before it triggers you, right?
Yeah.
Before it triggers you, is that the part of the gray matter already smaller than usual, or is normal?
Don't think so. So they've only done the scans. And the only thing is that it's not that every single patient, right? So this is where psychiatry is still evolving in terms of like research and all. So it's not that every single patient who has clinical depression will have decreased gray hippocampal density or gray volume. Okay. Yes, not all. Just that they found that in a big group of patients, they will have this. Yes.
Okay.
Yeah. Then we talk about the neurochemicals. We talk about the biological structures, that means the hardware, right? So we talk about the brain matter. So there are certain changes that goes on there. Then we also talk about at the molecular level, like everything else now. So we talk about the neurotransmitters. 3 main neurotransmitters are involved. The main component is actually serotonin, but I'll just go through them one by one. So noradrenaline, right, is a neurotransmitter. Neurotransmitter meaning that it's a peptide, or is a chemical that is involved in regulating certain functions. So noradrenaline is important in alertness, concentration, energy, attention, anxiety, impulse, irritability, etc., mood and cognitive function. Cognitive function meaning that the ability to focus, concentrate, memory, processing speed, right, and decision-making process. So noradrenaline is in charge of these few components. Then we talk about serotonin, right? So it's regulating obsessions, compulsions, memory, appetite, sex, aggression, and they co-share with anxiety, impulse, irritability. But again, the common theme here is mood and cognitive function. Dopamine gives pleasure, reward, motivation, drive. This is why when we watch TikTok every night before sleeping, then you don't feel like sleeping, because TikTok has designed it in such a way the algorithm is so smart that it can, like keep making your brain release dopamine and don't feel like putting it down. That's me anyway. I don't know about you guys, right? So yeah, so it's really annoying. This is really, really annoying, but it works super well, right? These guys have got the algorithm down pat. So, and the 3 neurotransmitters, basically they share in the regulation of mood and cognitive function. So a lot of depressed patients or anxious patients, your focus and concentration will tend to become impaired. So these are the biological basis for depression and anxiety or any other psychiatric disorders. So personally, not only me, of course, all the psychiatrists sometimes regard, I'm sure like Dr. Betty, you see some patients of yours, like they come with a lot of palpitations or shortness of breath, and we've done all the yes. So depression and anxiety, sometimes I call it the great pretender, right? So they come in mimicking a lot of other symptoms. I'll just share a few symptoms that I see very, very commonly. These are the few. I'll just go through them in the next slide. So for example, then we talk about cardiovascular, right? So patients, I had a 34-year-old Chinese male, sales manager, young guy, fit guy, plays badminton. He was a state player and stuff like that. Then he had some chest pain, occasional sharp pricking pain over the left side of the chest, palpitations, has done multiple scans, has seen all the cardiologists, Dr. Kim Tan, Dr. Surin, and a few others, all very well established cardiologists. Underlying PVC, but then they were told premature ventricular contraction, so it was said that nothing needs to be done. It shouldn't be able to explain why he has all these symptoms. Excessive worrying about heart attacks, and also whenever he hears someone talking about heart attack, right? And badminton players tend to die of heart attacks in the court. So whenever he hears about someone having a chest pain and it turned out to be heart attack, so he kept visiting doctors and getting reassurance, and ultimately the cardiologist referred him to me, right? So he was seeing this. So a lot of them present with a lot of cardiovascular symptoms, because I mentioned about the autonomic nerve function dysregulation. So they will have a lot of like palpitation, shortness of breath and all.
Oh, so
Then,
this is somatic, this palpitation and
yes.
all is related to the neurotransmitter?
Yes. So what happens is, like in people with anxiety mainly, and to a certain extent depression. So the autonomic nerve system, right? So the autonomic nerve system for the lay people, it controls certain functions in the body, right? So it's called autonomic because it is functioning on its own without us actively controlling it. Like if you contract a muscle, then we are actively controlling it. But the autonomic nerve function controls your heart rate, your breathing rate, your acid secretion, muscle tone, etc., without even thinking about it. My heart's beating 60 to 90 beats per minute, etc., right? So in patients with anxiety and all, there is a hyperarousal of the autonomic nerve system. So they tend to have all these fluctuations very, very rapidly. So you see some people with panic attacks, they will come to you with a blood pressure of 180 by 110. And then when you treat them and tell them, look, everything is okay with you, your troponin is okay, your CG is okay, then the BP drops to normal, and they're fine. So they tend to have a lot of this kind of like variability or lability of their functions. So heart rate and all is one of them. Breathing is another one of them. I had another patient whereby she complained of these symptoms called malat symptoms. Like I call it malat symptoms as in the malat hot pot malat, right? Okay. So it's like super spicy, super, like the peppercorn kind of spiciness. So she was not very educated, former commercial sex worker, very difficult childhood sexually abused when she was young. So she couldn't really articulate, she couldn't verbalize what she was expressing. So she always comes to me and told me that, hold that. So it's always a lot of like spiciness now. So I was Googling for the Western equivalent of spiciness, because spiciness is not something we study in textbook. So the Western equivalent of this symptom is called peppery. Right? So they call it peppery symptoms. So
peppery as in from pepper?
Yes.
Okay.
So the Western textbooks don't say spicy, right? Yeah. So some patients complain of like peppery sensation.
Oh, I see.
So that was interesting to me. Yeah, that was interesting to me because I did not know that beforehand, because this is my first patient that complained of the malat symptoms.
Oh, I see.
So this again,
peppercorn, Malat is actually peppercorn.
Yeah. So so again, hyperarousal of the autonomic nerve system, pain regulation gets a little bit haywire, simply because the pain pathway is regulated by serotonin and norepinephrine as well. So it will sometimes skew the pain sensation. And then very commonly, again, so I get referrals mainly from like cardiologists or gastroenterologists. So coming to the gastroenterologist, I had a 46-year-old Indian male COO, high position, high stress, always complaining of retrosternal epigastric pain, excessive bloating, nausea, loss of weight, appetite. So not relieved by conventional GI medications. Like it gets relief for a while, your Nexium, your Controlor, etc., It gets relief for a while, but it tends to come back every time he gets stressed out, and then he has to be on this medication for quite a long time. And again, they usually have some emotional components as well, such as insomnia, distress, anxious, depressed about his symptoms. And again, the dysfunction, work is greatly affected. Then finally coming to a very interesting presentation, which is again the body temperature dysregulation. So a lot of times people with anxiety or depression, they complain of inability to regulate body temperature, so they feel very cold. So I have patients coming to see me with winter jackets. Again, autonomic nervous dysfunction. So they are unable. Serotonin is one of the functions of serotonin is actually regulating body temperature as well. So when serotonin goes haywire, a lot of things go haywire. So patients present with all these symptoms.
Oh, I had a patient. Is it this yesterday? And she's an 85-year-old lady.
Oh, 85. Wow.
Yes, yes. Okay. She has palpitation and then don't know what. Documented AF actually, documented.
Okay. Okay.
So the cardiologist put her on amiodarone. So she's in sinus rhythm. But she came to see me because she has been admitted to ER like every 2 months.
Right.
Sounds like a panic attack and there's no AF whatsoever. And she says the symptom is feeling cold. So I thought, amiodarone, one of the side effects is actually thyroid dysfunction. So she could be hypothyroid.
Right.
Yes, but when I did the thyroid function, it's normal. And then I suspect, I told her, I think you have anxiety disorder. And she said, yes, actually I've been treated for depression for 10 years.
Oh, okay. Yeah, exactly. So I think maybe the event triggered her symptoms. So even though they're on medication, sometimes, I mean, especially if you're elderly, and MCO cause a lot of isolation. So I think all the more it triggered their relapse, possibly. I'm not sure. Right.
Possible.
Yep. Then I mean, so for medical doctors, then like most other disciplines, we call them functional or organic. Organic is like that means there's an underlying medical cause. Functional means it's in your head, right? That means that it's a psychosomatic, meaning that so psychosomatic or in your head doesn't really apply anymore, because nowadays we can more or less explain all the symptoms that's supposed to be imaginary, or like it's just like in your head kind of thing. So it's just because of this regulation of like all the neurotransmitters. So basically then I guess we assess the pre-morbid personality. So all these patients, anxiety did not start, let's say, during MCO or slightly before MCO. Anxiety has to be prevalent or innate in the person since young, right? That means in the teens or in the early 20s, they have always been the over-anxious, over-thinker, over-worrier, over-analyzer kind of person. Then, yeah, more likely that they will get this. And if, let's say, medically ruled out all the other causes, then possibly we like to think that it could be anxiety or depression. Family history, like genetic loading, obviously gives a clue. Then we like to understand that, hey, this could be something genetic, right? So if, let's say, father has it, mother has it, then obviously you would like to ascertain whether this person is really having these kind of issues. And then obviously you correlate the severity of symptoms to stage of disease. For example, like the case that you just mentioned, right? For her to have such symptoms, right, whereby she's having palpitations and everything, like that, then you expect to pick up something on the ECG or any other parameters. But then a lot of times you do all the tests, it's normal, and yet the patient's symptoms is so severe enough to
go to emergency.
Yes. So a lot of my patients on the gastros, they have severe bloating, severe pain, they lose weight and all. So I always tell them, look, for you to have such severe symptoms, if you do a scope, you probably find a big ulcer, a tumor, or something sitting inside your stomach, right? But all the time, when they do a scope, most of the time it's just some inflammation, then it does not explain the severity of symptoms. So if the severity of symptoms does not correlate, and the person's personality is more anxious type, then you would like to think that this could be anxiety or depression. And of course, we exclude all medical reasons. So if the patient comes to me with all these things, I will start treatment, but I will also refer them to the appropriate physicians, to make sure that it's not underlying thing. Then temporal relation, meaning that you compare, if let's say the person has gone through a stress, and soon after that the patient develops all these symptoms, then you like to think that, hey, it could be related to depression or anxiety. So why do we need to treat depression, right? So depression, okay, so it's a very debilitating condition. It makes you depressed, besides being suicidal and all. But what other more important components we feel is that it causes impairment in your daily functioning. So a lot of times a person with depression and anxiety, most people when they're sick, it's absenteeism. They are unable to go to work. They are unable to turn up for work. Even online, they are unable to go on it. But depression and anxiety, physically they appear normal. So they are still present physically at the office, but then their mind is not really there. So it's actually presenteeism. So they're physically present, but then they're not working. Yeah, they're not able to function. So it causes, so it causes an impairment in daily functioning. So this is where it is now. And that is comparable to that of major chronic illnesses. It costs a lot to the economy. Severe MDD causes 24% of the year out of row, meaning that they are unable to attend work for 24% of the time in a year, or 386 million days of row disability per year. Extreme cases, then patients are unable to fend for themselves. So in my line of work, then we see severe depression whereby the patients are unable to even dress themselves, or they do not have the energy or motivation or ability to just get up, go, have food, make breakfast. So they just lie in bed most of the time. Which areas of functional impairment? We talk about occupational, work-wise, family. So they're unable to sort of like get involved with the family or get engaged with the family. Socially, forget it, right? So if let's say, so I tell my patients, look, you should still try to, if you can, but maybe just go out with just 1 or 2 friends that you can trust or you're close to, rather than in a group, because too much stimulation, your focus and concentration is not there. So obviously you're unable to focus and concentrate. So I always tell people that if a person is depressed, when you see a person depressed, a loved one, for example, or a friend, the tendency is to grab the person and come, join me. Let's go to a party, or let's go for a holiday, go to Bali, crowded, full of people. That's probably the worst thing to do to a person who's going through depression. So I always compare to, like, let's say now you have dengue and your fever is 40 degrees. The last thing you want to do is go for a holiday or go to Mid Valley on a Saturday where it's crowded and full of people and it's noisy and you're having body aches and pain. So a lot of times people with depression are unable to portray that, right? Because outwardly they appear okay, but the brain is just unable to function. So cognitive function, the ability to process information, focus, concentration, ability to make decisions is all impaired, right? So they are unable to focus properly. And even sexual function. So for a couple, husband and wife, then that becomes, it affects the relationship, right? So once we have diagnosed, and so we talk about management. Tonight, I'm going to focus mainly on medication, right? But there are just so many components to look into. Actually, we talk about life. I tend to remind my patients that depression and anxiety is a medical condition like all other medical conditions, regardless whether it's diabetes. So the simplistic way to explain things is like diabetes is just decreased insulin. I mean, this is a very simplistic manner. I hope no endocrinologists are on board. So it's just like, okay, diabetes, low insulin. Depression, low serotonin, right? Again, depression is more than just low serotonin. There's so many components involved, right? There's neurobiological, neurohumoral, and all the other things. But for the sake of like to explain it simply, we talk about serotonin level. So if you talk about these things, besides medication, then you do lifestyle change, right? You have to eat healthily, exercise regularly, work-life balance, spirituality is important. If a person is agnostic, then you can just do meditation, yoga, etc., etc. All this will help to an extent. So just like diabetes, if you take treatment, you have to change lifestyle, you have to eat healthily, exercise regularly, etc., etc. So it's the same thing. All medical models are the same. So once the diagnosis is established, we like to initiate treatment. Ideally, it depends on the severity. Medication is important simply based on the fact that I presented earlier, the neurobiological changes, right? The neurotransmitter changes. And then psychotherapy is where we do counseling, whereby a person goes through. So for example, a person who's depressed typically have a lot of negative automatic thinking. For example, I'm not good enough. So you hand in an assignment to the boss. The boss says, hey, good job, but you know what? Page 36 and page 38, you made some mistakes to the statistics, but otherwise it's a good job. A person with depression and anxiety then will tend to focus, they maximize or they magnify the criticism, and they minimize the compliment that the boss gave, that you did a good job, it's really a good thing, just a mistake here and there, just correct it and it's fine. Not that they focus on that. Why did I make the mistake? Why did I make the mistake? I shouldn't have made the mistake. I should have double checked. I should have triple checked. So a lot of them have this kind of negative thinking that we always try, the psychotherapy psychologists or psychiatrists try to identify the negative thinking, try to challenge their thinking, try to modify their thinking. If the modification of the thinking is not successful, then what else can you do? So we have to just keep running through and try to identify. But before fixing the problem, we have to identify the problems first. So this is where psychotherapy is usually very, very helpful. My patients will usually ask me, do I really need psychotherapy? My answer is, I think all of us need psychotherapy. It's just that it's harder for psychiatrists to get psychotherapy because all the psychiatrists know me, right? So it's difficult to divulge things to them. But ideally, I think everybody should get. Again, with the permission of Xavier, and this slide is very nicely done. So we talk about treatment plan. So when we talk about treatment plan, we all follow guidelines. Malaysia has the CPG, Clinical Practice Guidelines. We follow a lot of the Canadian network for the CanMed, the Canadian network for mood and anxiety treatments. We follow a lot of the British and the Royal ASAP and also the American Psychiatry Association. So these are just some of the guidelines worldwide that we tend to follow. But the gist of it is like second generation antidepressants are commonly recommended. So I'll go through the treatment plan with you in a short while. So pharmacotherapy, meaning that medical treatment, right? So pills, the word that most patients do not want to hear, right? So do I really have to be on the on this medication? Can I just do it, like by praying more, by like making myself more resilient, stronger, etc., etc. I tell them, well, if you can successfully use willpower to control diabetes, then yeah, maybe you can try that with depression. But most of the time, we don't recommend that. So we talk about treatment, we talk about lifestyle change, we talk about counseling support or psychotherapy, and then we talk about pharmacotherapy. So you select antidepressants, you'd like to follow them in 2 weeks' time. Response time, this is just a rule of the thumb kind of thing. It's just my feeling. It's easy for I think most doctors, if you're listening in, then it's easy for you to give the patients an expectation of the progress of their expectations of the progress of their improvement. So first 2 weeks is usually about 10 to 20% improvement. So first 2 weeks is for me to see if you have any side effects rather than if you have improved. Even if you have improved 10 to 20%, to us, it is something, but to the patient, it's nothing. 10 to 20% is not. So most patients, when they say, I want to be better, it means that they can go back to their old life, right? So after 2 to 4 weeks, we talk about 20 to 40% response. This doesn't apply to everyone, of course. There's idiosyncratic response. So some people take 6 months to respond, some people take 3 days to respond. And then by 1 to 2 months, which is 4 weeks to 8 weeks later, then you should really get 40 to 80%. So I go by weeks now. So first 2 weeks, 10 to 20, 2 to 4 weeks, 20 to 40%. Then 4 to 8 weeks, then 40 to 80%. So it's easy to remember, and it gives the patient a more objective kind of like expectations about when do they see improvement. Because if let's say after a month, they only improve by 20, 30%, then like as it is you're depressed, as it is you're negative, as it is you have very low confidence, then all the more you tend to give up, right? So you feel like it's not worth going back to the doctor, I will not get better, and this is where we have to correct that mindset. And for I think for the doctors listening in, and if they're the public people listening in, then these are the antidepressant classes that we look at. We talk about tricyclics, SSRIs, SNRIs, and the others. Tricyclics, I'll go through them in a short while, not individually, but in its own class. So tricyclics is basically, it's called the first generation antidepressants. It was a very serendipitous, very accidental find, the first generation of antidepressants. They are known as tricyclic antidepressants. They were discovered and invented in the 1950s. And then the main mechanism of action is basically serotonin and norepinephrine transporters inhibitors. So I was telling you about serotonin being deficient, right, in the neurons and all. So the neurotransmitter serotonin gets pushed out from the cell, then it goes back in. It's like a recycle kind of thing. So if there's a deficiency, so what we want to do is want to block the transporters that transports the serotonin molecule from inside the cell to outside the cell between the neurons. So the main mechanism of action is serotonin and norepinephrine. So these two regulate mood, like what I showed you earlier. The only problem is the tricyclic antidepressants, first generation, they were very effective, too effective. So it's like the cluster bombing. It's like a dirty bomb. So if the enemies are hiding in one building, then when you throw this bomb on the building gets destroyed, the enemies get killed, but unfortunately the whole area around it gets destroyed as well. So you have anticholinergic side effects, muscarinic side effects, histaminergic side effects. So they put on weight, they are very sleepy, they have dry mouth, so for the Chinese, I always tell them that this medication is quite heaty, right? Because dry mouth, constipation, dry eyes, like urinary disturbance, and also, so it tends to create a lot of this. So we don't use a lot of these first generation antidepressants. Don't get me wrong, they're effective, but they have a much higher side effects profile. So first generation, for 20, 30 years, it went on effective, but then a lot of side effects. Then in the 1980s, it came with the second generation antidepressants, sorry. They are known as the selective serotonin reuptake inhibitors. So most of us know it as SSRI, famous ones like Prozac and Lexapro. So I think most people will use this, and this is the one that we usually recommend for most people to use because it's well known, it's quite clean. It was invented in the 1980s. Prozac, there's a movie about Prozac, there's a book about Prozac's fluoxetine. And then Princess Diana took Prozac apparently for whatever issues that she was going through. The main mechanism of action is serotonin transporter inhibitor. So now it acts only on one neurotransmitter, which is supposed to be the main culprit. So it's cleaner in that sense. And the beautiful thing about SSRIs is that every SSRI has a little bit of extra property. So some of them are activating. For example, Prozac, which is fluoxetine, or Zoloft, which is sertraline. Prozac acts on one part of the brain, the prefrontal cortex. It acts on the receptor called 5-HT2C antagonism. So what it does is it will activate the person. So for patients who are very lethargic, low energy and all, Prozac is actually quite good. Sertraline blocks the dopamine transporter a little bit, so it increases dopamine level as well a little bit. So it's a little bit activating as well. So for some people who's going through this kind of like low energy, low motivation, these kind of medications may help a little bit. So the SSRIs, every medication has a little bit of a special property. Effective and cleaner, right? Much cleaner than the first generation. Then subsequently, we have the third generation, which is basically in the 1990s or 2000s, it was invented. Venlafaxine, duloxetine, and desvenlafaxine. Just now, let me just go through a little bit. We talk about the second generation, then you talk about the SSRIs, right? SSRIs, these are the ones. Prozac is fluoxetine. Zoloft is sertraline. Lexapro is escitalopram. So these are the ones that we use very, very commonly. Escitalopram is the #1 selling antidepressant, if I'm not wrong, in the world at this moment, simply because it's quite clean, it's easy to use, the price is reasonable, and I think most people are familiar with it. So it's a very effective drug. The third generation, then we talk about this few, the main mechanism of action. So first generation acts on serotonin, norepinephrine, and a lot of other receptors, too dirty. Then second generation, they felt like, hey, let's target serotonin. Then after a while, they discovered that, the first generation was quite effective, just that it's a bit too dirty. So let's just target on serotonin and norepinephrine. So it's the targeting on two transporters to increase the serotonin and norepinephrine, what we call the synaptic cleft, so that the neurons can regulate itself. Has the advantage of both regulation. And because, like what I mentioned earlier, serotonin and norepinephrine has a role in the pain signaling process, or the pain pathway. So these are the two neurotransmitters involved in the pain pathway. So the SNRIs, these are called the SNRIs, serotonin norepinephrine reuptake inhibitors. They have a role in pain regulation as well. So it's quite useful for some people with pain. And then other newer antidepressants, vortioxetine was launched in Malaysia in 2015. Agomelatine, which is valdoxan, was launched in 2009. Mirtazapine has been around since 1990s, 80s. It's called Remeron. So Brintellix, valdoxan, and Remeron. So how do we choose which one to use? So it largely depends on like certain profile of the patients. Certain symptoms, then it is quite useful to treat the patients. For example, SSRIs, people are familiar with it. So a lot of us use SSRIs. So for the psychiatrists, then we have other options. Like for Brintellix or vortioxetine, it is good to improve focus, concentration, and memory, because it will increase glutamate as well, which is very important for regulation of focus and concentration. Agomelatine acts on the melatonin receptor, so it helps regulate sleep in a way. Mirtazapine is very sedative, so it's good for people who have some sleep issues with and depression as well. So how long do we treat it for? So acute phase, right? So patients start to respond. Acute phase is about 4 weeks to 8 weeks. Continuation phase is about 6 months to 9 months. And then if let's say this is the second or third episode, we have to maintain it for a period of time. How long? Rule of thumb, okay? I mean, based on studies, and also this is just how I will share with the primary care doctors or the other doctors who treat patients with depression and anxiety. First episode, at least 1 year, because 1 to 2 months plus 6 to 9 months, so it's approximately 1 year. But if the person gets well, then has a second episode, maybe 2-3 years later, then you have to treat a longer period of time. 2 years, but then it's very arbitrary because it really depends on the patient's severity, how fast the patient relapse. And then third episode is 3 to 5 years, and you would like to consider lifelong treatment as well. I believe this is my last slide. So in summary, depression is frequently comorbid with other psychiatric disorders, especially anxiety disorders. It's debilitating. It is not just in your mind. It can cause severe functional impairment. So I think what Dr. Betty shared earlier is very important as well, that this is a personal testimony, personal sharing. So I think that is important when it comes to that. A lot of people think that, hey, you're a psychiatrist, you can never be depressed, which is absolutely crap, right? I mean, of course, we all get sick, we all get depressed. And the thing I'd like to emphasize always is that you cannot snap out of depression. And the most important thing is it is treatable. So if you come to us early enough, the earlier you come, then the easier it is for us to help the patient. Okay. Yes.
Questions? Any questions? Okay, let me just ask you
Sure.
one question.
Sure.
The fact that you said that spiritually is important, is it really important, you think?
Yeah, I think it depends. I mean, it depends on what kind of upbringing you have. So if a person is agnostic, so like so we always try not to impose religion on people, obviously. I mean, we are medical doctors first of all, right? But then if let's say religion is important to that person, it's just like talking to someone or ventilating, right? Use the other person as sounding board. It doesn't work for everyone. So psychotherapy doesn't work for everyone. If let's say a person who is not used to verbalizing their emotions and all, then obviously you cannot tell them, hey, look, talk it out with someone and you're going to be okay. They will find it more stressful, in fact, right? So spirituality then depends on your background, it depends on your upbringing, it depends on your own belief. So if you're a person who believes in God and has a close relationship with God, then yes, then that will be important. So if you're agnostic, then what do you do? Then you do meditation or you do yoga.
Okay, so do you try to convert patients who are depressed?
So I think as all medical professionals, we have to remember that we're medical professionals first now. So religion is not something that I mean it's not something that we should impose. That's my belief. So when I was a lecturer in UM, so we always tell our students as well, our master students, that it is important for you not to impose your values, just that you shouldn't impose your values, right? Just because, look, I can do this doesn't mean that I expect you to be able to do it. So religion is the same thing as well. So as far as I'm concerned, then no. I mean, personally, I don't. Unless the person asks me about what religion I'm from and everything like that, then I'll share a bit about that. But if they don't, then religion usually doesn't come into the conversation.
Okay. because as I went through a lot of things,
Yeah.
of course, a lot of people try to convert me,
Mm.
and find that really I'm very scared of it. It gives me panic attacks. Truly, I really freak out when people try to convert me. Okay, so there is a question.
Yeah.
And a severely depressed patient, I always ask them to avoid or postpone major life decisions like resigning a job, closing a business. How do you advise them there?
Yeah, so absolutely correct. Right. So this is actually a very, very important thing as well. So this is a very good statement. I always make it a point to tell the patients that, for example, I had a patient who was building his dream home, then he became depressed. Then the first thing is like he wanted to sell it, because when a person is going through depression, they become very depressed and negative views about everything. So it feels like all my children are overseas. What's the point of having a big bungalow? It was in Desa Park City, by the way. So, what's the point of having a big bungalow? Like I have the AV room, I have this room, I have that room, but then nobody comes home. My children come home once a year. So I wanted to sell it. I said, please don't, right? Because you can sell it after I treat you. Give me about 3 months to 4 months. Let me treat you, get you better. When you're in a better state of mind, then you want to make a decision to sell. That means it's for a more rational point of view, then by all means. But then if you're doing it when you're emotionally down and negative and all, then obviously it's not a good idea. So what Ng has suggested, I think it's absolutely true. I stand by that. We really have to tell the people that, look, you have to postpone any important decisions, whether it's changing job, moving out. I mean, like moving to a let's say they're supposed to move to a country, then they say, no, now I can't. So treat them first, get them better first, then see how it is.
Okay, another question I'll ask you is, you see, when you say that, okay, if genetically father has depression, mother has depression, chances of a child then growing up to have depression is higher, and it could be genetic. Could it be upbringing? It's not just genetic.
Yeah, so it's epigenetics. So the thing is like, so another example I like to give is like, okay, two babies, like let's say they are from the same family, a few months, 1 year apart, whatever it is, but still infants. So one baby is, nobody has taught them anything, right? They haven't grown up enough to develop any sort of like personality. So one baby is like the mother can pass from one stranger to another stranger to another stranger, and the baby is like gurgling away, very happy, very cheerful, not disturbed at all. Then like very, very secure. Then there's another baby whereby the mother, same family, mother is carrying. The mother just wants to put the baby down for a short while, just to go to the corner to get the pampers, and the baby is crying, holding on, grabbing the clothes and all. So separation anxiety. Nobody has taught them anything, right? So these two babies growing up in the same family. So obviously this baby who is more introverted, who has more social anxiety, needs a lot of nurturing, needs a lot of like, like a care and security for the child to grow up more secure, but already predisposed, like there's already innate anxiety in this child. So it's easier for this child to develop, let's say, stress or anxiety eventually, if not managed properly, compared to the other baby. The other baby is probably happy-go-lucky. Doesn't mean that, doesn't mean that the child will not develop depression or anxiety, but it's just like, if they do develop it, then they will probably come out of it a bit faster.
Oh, there are babies who are like that, who cannot.
Okay. Yeah, I mean, there are, right?
Yeah, whole, but cannot see strangers.
Yeah.
And that is part of, could be part of anxiety, right?
I mean, it's just
difficult to assess, but
yeah, I mean, it's not
I never
anxiety.
saw it that way.
Yeah, it's
I was
not
like
anxiety disorder, right? But
was
then like
the parents' upbringing, like so possessive of the child.
yeah,
But actually, maybe the child has anxiety disorder.
right. So chicken or egg, right? So the child is a very anxious child. Obviously, the parents will have to pay more attention to it. So we will think that the parents are coddling the child, or like overprotective, but the child actually needed that, and they have a chance to grow, and so on and so forth. Chicken or egg, yeah.
Yeah, because sometimes I feel like, for example, okay, I don't have it because my dad, right? My dad is a very scaredy cat. So everything is like, oh, don't do. Oh, don't, after you die, you know.
Mm.
But I'm
Okay.
the direct opposite of him. And
Okay.
it didn't make me become him. But
Right.
he has anxiety disorder because I never diagnosed lah, I guess, because he did not fly.
Yeah, yeah, yeah.
When he
So,
flies, he gets scared.
exactly.
But
So a lot of people, yeah, exactly. I mean, good point. A lot of people, I mean, imagine our parents, I think they will never, ever, ever go see a psychiatrist, right? Because they are not cuckoo, right? But in actual fact, it's just anxiety, right? It's just anxiety, it's just depression, which is treatable. It's just such a big taboo for that generation. So the younger generation is better.
yeah,
They will come.
the younger generation is like perpetually needing therapy. my kids are like, mommy, you need to go for therapy.
Yeah.
I need to go for therapy. They need to go for therapy.
Right. So they're open to it. And then to them, it's like, hey, look, nothing is wrong. You know, like our generation, then we still think, like,
If
oh,
they don't get therapy, they
yeah.
are not normal.
Yeah.
It's just so
Be-
odd.
Because like if you talk to friends, then yes, I mean friends are usually supportive, you know, they can help you point out some of the mistakes and everything, but they're not professionals, you see. So a lot of people misunderstand that talking therapy is just like, oh, you know, I listen to you, I be the sounding board, and then, you know, be supportive, that's all. No, it's nothing like that. What we are trying to do is we're trying to dissect the thoughts, the negative thoughts that you have. And then what we're trying to do is we try to help you modify them where possible, because it's not easy to just change your thoughts, right? So you modify, and then as you modify along the way, then if you can't, and then we will ask you, so after you change your thinking, how successful were you able to, okay, feel better? You say, oh no lah, that one is just, you know, like I was just trying to cycle myself, it didn't work. Then we say, okay, what else can we do? Then we keep analyzing and trying to find a way that's workable for the patient. So it's a lot of that. It's not just, okay lah, tell me your problems. Then talk.
Okay, are psychiatrists, how you call it, keen to do psychotherapy? They can do psychotherapy, right?
Yes. So
But-
now, okay. So now the question is, we are keen, but do we have time? For example, right? We have about 400 plus psychiatrists, if I'm not wrong. 400 plus psychiatrists in Malaysia for a population of 30 plus million. Singapore has 6 million population. They have about 300 plus, if I'm not wrong, about 300 plus psychiatrists. Canada has a population of 36 million or so, and they have a population of 4,000 psychiatrists, right? So that is ample. We are nowhere near. So for us, even to treat with just medical treatment and even then, we are so short-handed. But the good news is that there are more psychologists involved right now. It's just that psychological fees are quite expensive. Right? They are not like our medical fees, whereby it's regulated by ministry, right? So by the act, so we cannot charge too expensive a rate. Psychologists, they don't have the fee
even
schedules.
for psychotherapy, also you have a ceiling for your charges?
For us, yes, it's 350.
Oh, you have a ceiling.
1 hour, 350 ringgit, if I'm not wrong. Yes.
Oh,
so psychotherapy for 1 hour, 45 minutes or 1 hour is about 350 ringgit, if I'm not wrong, or 300 ringgit. I don't think it's 350. Psychologists charge between, it depends, but from what I heard, my patients told me 350 to 450, I think, depending on where, who they are.
I see.
Some are about 300, yeah.
Okay. I think we have one more question.
Yes.
Okay, hold on. Now let me just type. This
Saffron,
one.
is it?
Okay. Yeah, any thought about the use of saffron? Saffron is something you cook with, right?
Yeah, I think
not the thingy, the yellow color thingy.
Yeah. Did they talk about for COVID as well? I don't have any experience about this, about saffron for depression and anxiety. We have a lot of other supplements. Recently, ashwagandha is promoted a lot. I don't have any experience with that. The only thing that we have evidence for is St. John's wort and supplements and certain supplements and then they talk about almond, they talk about dark chocolate, they talk about banana, but you have to understand that if you're going through just depressed mood, this is what I think. If you're going through depressed mood, that you fail your exams, you feel lousy, you know, I broke up with the boyfriend or girlfriend, you feel lousy, and all, then I think supplements will probably work to a certain extent. If you're going through clinical depression or major depressive disorder, whereby you cannot even get up to brush your teeth or just to go change, you go to work and all, then I don't think any amount of saffron or any other supplements will work. Sometimes even medications, even with medications, is controlled, serotonin transporter inhibitors and regulators and all. Even with that, sometimes we have a challenge trying to get them back to normalcy as soon as possible. So I think supplements probably will not have a role in those things. Yeah, I mean not as severe. Yes.
Okay, your MDD, right? Your major depressive disorder does not necessarily need to have psychosis, right?
No, only in the very, very severe form they can have psychosis, but that one is usually quite an emergency. Actually, we need to hospitalize them, need to get them admitted, because that one, then we worry that the hallucinations will tell them, look, you kill yourself and all. So we are worried about that. So that one's actually a urgent matter.
Okay, are there any more questions? If not, we will thank Dr. Joe, and I'll see you back on Wednesday.
Sunway Medical. Okay, next Wednesday. Okay, thanks, Betty. Thanks everyone for attending.
See you. Bye,
okay.
guys.
Good night. Good
Thank you
night.
very much.
Bye-bye.
Thanks,
Bye.
Joe. See you.
No problem. Bye-bye.